Thank you for joining us. Thanks for taking um, the little time you have during the day to join. I know that it's August and you're probably starting to see a whole lot of kiddos with a whole lot of challenges. Hopefully, we can help a little bit. So the goal of this program is to try and increase your confidence and capacity to prescribe. Why? Because you provide more behavioral health care than any behavioral health provider, more than psychiatrists, more than more than anyone else. Um, Peak time for well visits is now. 75% of behavioral health starts with a pediatrician. Kiddos see you more often than not. Oh, sorry, kiddos see you more than any other provider. You also prescribe 85% of psychotropic medications. And the last study that was published in Pediatrics from the AAP just about a year ago, that 60% of PCP visits, kiddos that came in with anxiety, came out with a prescription. So what we wanted to do is essentially be inspired by the REACH program, if you know it, and try to create a case-based educational program that, yeah, helps increase your confidence in providing care, mostly in prescribing. If we go next. So, who we are. So, Dr. Sara Harmon leads behavioral health. She's a behavioral health medical director at Adovcare Doctors, which is New Jersey's leading primary care group. My name is Shai. I'm one of the founders of Fort Health. Fort Health is a provider of behavioral health care. The unique thing about us is that we work very closely and indeed try to integrate with pediatricians. So we have on the left side the referral model, which is you refer kiddos to us. We take the referral, we update you, we provide care. We take all insurances in New Jersey and most insurance plans in PA and Y. On the right side is collaborative care, which we developed in partnership with Dr. Harmon and good folks at Adovcare, and it's now available for everyone, where we integrate care by virtually embedding a behavioral healthcare manager and a consultant psychiatrist at a primary care practice. I won't get into too many details on that. You have my contact info and we can talk more about it. And I know that we also have one of the practice leaders from Advocare who was the first one to implement it at his practice and indeed is a tremendous advocate for the program. That's Dr. Saluja. So as always, thank you, Dr. Saluja, for your partnership. So with that, let's get started. Please use the Q&A function. Please use the Q&A function to ask any questions during the session. We'll pause if the question starts to repeat itself a couple of times.
Okay. So just a quick disclaimer. Also, this is educational purposes. This is medical recommendations. Hi, everyone. Thank you for being here. I'm sorry about the delay with starting. That was my technological error. Okay, so today's presentation is really about non-stimulant medications, but I wanted to revisit a handful of things that we talked about last time. So some of the questions I got last month when we talked about stimulants were pertaining to growth. And so I did go back and read some more of the literature, and ultimately it's still somewhat inconclusive. There was a review in 2008 that looked at a bunch of studies that showed that there were statistically significant delays in height and weight for patients on stimulants. Granted, these are not huge in size, but they are statistically significant. And then those deficits attenuated over time. So they, as patients stayed on stimulants, the effect on their height and weight seemed to decrease. The deficits may be dose dependent, and they found that when you stop treatment, there's normalization of growth. So within 2 years after stimulants were stopped, kids returned to their former growth percentiles. There are more recent studies that have said, that perhaps this is less of an effect than we thought. There's a CHAD page that cites some studies. And one of those, the number that was cited was 1 to 2 centimeters below projected height level. That's what I typically tell patients. And it's not in every child, right? So some portion of kids may see their height be impacted, but it's not everyone. And then, there's a longitudinal study that looked at retrospective data. And they basically found that if you look back and you look at a cohort of people that have taken stimulants and people that have not taken stimulants, they didn't see a difference in height attainment based on having taken stimulants. I think that probably represents the reality that most people who are taking stimulants are not taking them every single day without breaks throughout their entire developmental trajectory. The other thing that I would just comment on is there is some suggestion that ADHD itself impacts height growth, and that people with ADHD, whether or not they were taking stimulants, are on average a little bit shorter than their non-ADHD peers. I wanted to talk about 2 resources that I am working on with Shai, that I will have him share with the group that has registered for these educational sessions. One is a controlled substance contract, again, for prescribing stimulants. I typically use this for my adult patients. And the second is a handout that you can use or edit as a resource for families who are trying to find stimulants during our current stimulant shortages. So those are just some resources that we are working on creating or getting ready to be able to share with you. Okay, so today is about non-stimulant treatments though. So what I wanted to start with is not my triangle, but if you look at the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry, they basically present a triangle of treatment for ADHD. So this is what I kind of think about it as. Kids who are well supported for ADHD and young adults typically are receiving some sort of pharmacology, whether that's a stimulant or a non-stimulant, behavioral therapy of some kind, and then school support of some kind, whether that's a behavioral support like a daily report card or accommodations, classroom management systems, etc. A lot of what I'm presenting today, I looked at, there's actually a 2024 study. This was published in Pediatrics, Treatments for ADHD in Children and Adolescents, a systematic review. So they looked at 312 studies. And they're looking at evidence for medication, psychosocial interventions, parent support, nutrition and supplements, neurofeedback, exercise, etc. So they looked at really the gamut of interventions for ADHD. And obviously today has a somewhat of a medication focus, but I will talk about some of these non-medication strategies as well, because they kind of fall in the non-stimulant treatment of ADHD. Okay, so something I want to emphasize with ADHD, this is a Russell Barkley quote. He's a PhD psychologist, expert in ADHD, and he emphasizes that ADHD is not due to a lack of skill or knowledge. It is instead a problem of sustaining attention, effort, and motivation and inhibiting behavior in a consistent manner over time, especially when consequences are delayed, weak, or absent. Thus, it is a deficit in performing what one knows, not a deficit in knowing what to do. So if that's the problem, you can imagine that interventions that take a kid and sit them in a classroom or in a therapy room and tell them what to do in certain situations, but then don't actually go out there and help them apply it in those situations are pretty ineffective, right? Because the problem isn't that the kid doesn't know what to do. It's that they can't apply that knowledge in the situations where it's relevant. They can't contextualize. Okay, so okay. So in terms of some of the interventions, again, these are non-stimulant. These are also non-medication interventions that they looked at in this paper. They looked at youth-directed treatment. So these are behavioral treatments for kids. I will say these almost all included a parent component. So I think it sort of falsely says these are youth-directed treatments. Almost all of them were like, there's a component for kids and a component for parents. They were highly diverse. They had different outcome measures. Ultimately, there was a moderate strength of evidence that these are helpful for ADHD symptoms, but there wasn't an improvement in disruptive behavior, and there was no improvement in academic performance. They also looked at parent-directed treatment, so that would be like parent management training or PCIT. There was a low strength of evidence. However, they found that overall in a bunch of studies taken together, these helped with ADHD symptoms as well as broadband scores. So that's like a clinical global assessment, as well as disruptive behavior. They found that functional impairment was not improved. And then there's also cognitive training that's like sitting in front of a computer and clicking or inhibiting your distraction. They did find that in these studies, ADHD symptoms were improved. There's a low strength of evidence. Functional impairment was not improved, and disruptive behavior was not improved. And again, this is the 2024 pediatrics paper that is looking at all these interventions. Okay. With respect to medication, I wanted to share some resources that I use commonly because, there can be some complexity to prescribing for ADHD. I do have a lot of patients on multiple medications, and I use a variety of medications. So this Carlat Child Medication Fact Book for Psychiatric Practice is a great book. I think it's like $40. I use it a lot. You can get a PDF version of it, I believe, as well. And then this Simple and Practical Mental Health is a website. There's a annual fee that you pay, and it's a lot of evidence-based summaries addressing different questions that apply in psychiatric care. The Carlat book is pediatric focused. The Simple and Practical website is adult focused, but I do use it a ton for as a reference for kids as well. Okay. Okay, so I want to make and we will talk about medications, but I want to make some comments about non-medication strategies, again, because they are really a pillar of ADHD treatment. And I think that sometimes kids and families get directed to therapies that may not be the most effective. So you saw that they, this meta-analysis or review paper indicated that direct intervention to the child as well as parent intervention can be helpful. And I would just again caution that really the direct intervention to the child in these studies often has a parent component. So I really look for parent directed behavioral management training as my like key therapy for kids who have ADHD. On the left-hand side of this slide, you can see these are the kinds of things that a therapist should be talking to parents about. So why kids misbehave, how to pay attention and praise their child, how to set up a token economy or a positive reinforcement system, how to use a timeout in a limited manner, and then how to manage behavior when they're outside the home. These are kinds of things that behavioral management training programs will address. So names of types of therapy: parent management training, parent-child interaction therapy. There's also an online resource. This is pretty inexpensive. I think it's like $20 a month. ADHD Dude. He's a LCSW that has a lot of parent training resources for ADHD. And then there's programs through CHOP, as many of the people that are local to where I work may know that they have a parent boot camp for ADHD, which is also parent training. School intervention. So I talked about parent training or behavioral intervention being one piece of the puzzle. School intervention is the second piece of the puzzle. Interestingly, school intervention in this recent review that came out was not shown to significantly improve ADHD symptoms. In most cases, the studies that study school interventions do show that kids have improved academic performance, but it's not always statistically significant. So ultimately, I think school supports are really important, but interestingly, they don't seem to necessarily be impacting ADHD symptoms. I do think they impact other things like kids' success in school, their academic success, their ability to stay in school and not be suspended for behavior, which obviously helps them learn better. And I think that they help with confidence as well. So kids that are well supported in school feel more confident, and they then, I don't have evidence to support this, but I would guess that they have lower rates of comorbid anxiety and depression if they receive school supports. So in terms of school supports, there's a lot on this slide. This is a great book. This is by Russell Barkley, Attention Deficit Hyperactivity Disorder, a Handbook for Diagnosis and Treatment. This is a more detailed book. It's meant for providers who treat ADHD. It has a whole chapter on school interventions. And the information that I have in here is from this book. But so what does it mean to support a kid in school for ADHD? So it might mean a 504 or an IEP. It means helping kids replace whatever they are doing with effective other replacement behaviors. So if they're becoming distracted and wandering around the room, you know, we want to really be clear on what we want them to be doing, not just reward them for sitting still and being quiet, because that doesn't help them learn either. And again, we want to include academic performance, right? It's not that we just want kids to sit in school and be quiet. We want them to sit in school and learn, or stand in school and learn. And I always try to, I mean, every kid's ADHD accommodations and supports in school are going to look a little bit different, but big picture, I try to encourage families to advocate for a mixture of proactive strategies. These are what we would call accommodations, right? This is changing what we expect the child to do, because we know that they have different abilities. So an example, if you're thinking about learning how to play baseball, this would be like having someone hit off of a tee or take batting practice, right? We want them to hit a home run in a baseball game, but we're not going to have them only play baseball games. We're going to have them do other stuff that might help them get to that goal. And so this is helping teachers understand ADHD better. It might be preferential seating. It might be modifying assignments or expectations, including homework expectations. It might be presenting material in different ways, so written versus auditory, etc. And then we're looking for reactive strategies. So this is the reinforcement of what we want and the negative reinforcement of what we don't want. It's asking the kid to meet the expectation, whatever it is. And then rewarding them for the aspects of their behavior that are positive, and having consequences for those that are negative. So that would be like if you're in a baseball game and you're a baseball player and your coach makes you run laps if you don't, you know, perform as expected. Or if you're in a baseball game and your coach, you know, takes everyone out for ice cream because you had a great game, right? It's you're doing the thing that we want you to do, and we're offering some incentives or some negative incentives for the undesired behavior. And again, I'm sure probably everyone has heard this before, but the negative reinforcement should be immediate, and it should be less common than the positive reinforcement. So we want lots and lots and lots of rewards and positive praise, and a minimal amount of consequences if we possibly can help it. Okay. Medications. So this focus of this conversation today is also around non-stimulant options for managing ADHD from a medication standpoint. And so basically there's two major categories of medications that we use. The alpha agonists, so guanfacine and clonidine are one, and then the norepinephrine reuptake inhibitors, or that would be Strattera and Qelbree, are the other. So guanfacine and clonidine, they're both centrally acting alpha-2 agonists. The guanfacine is more selective, clonidine is more generally acting, but they're still both centrally acting. Basically what they do is they increase norepinephrine release, so effectively the same downstream result as our other medications for ADHD. They have guanfacine has a little bit of a longer half-life, clonidine has a little bit of a shorter half-life. They both have similar side effect profiles: sedation, dizziness. You can have some drop in blood pressure. These are they were originally blood pressure medications. So sometimes people can have a little bit of orthostasis with these medications. When I think about guanfacine, I use it super commonly both by itself and also as a adjunct to stimulant medication. It's helpful for somebody who has a comorbid tic disorder, or who has tics that onset after they start stimulants. And you have less appetite suppression with guanfacine and clonidine as compared to some of our other medications. Also, if you look at some of the data a little bit more closely, alpha agonists in general, so both guanfacine and clonidine, tend to be helpful for impulsivity and hyperactivity in particular, as compared to inattention. So if you separate those out, I really like to use alpha agonists for kids who are impulsive and hyperactive. Clonidine, again, same mechanism. It's more sedating than guanfacine, so I'm commonly using it in kids who have insomnia to kind of cover them for sleep and ADHD. And we want to be careful of abruptly discontinuing clonidine due to the possibility of rebound hypertension. So if you stop the medicine suddenly at a higher dose, your blood pressure can sort of spike at the time of stopping the clonidine. Okay, so there's dosing information in here. I'm not going to read through every single dose. There are short-acting and long-acting versions of both guanfacine and clonidine. The short-acting are not approved for ADHD, but they are commonly used off-label for ADHD, and I do use them all the time. The long-acting are the ones that are approved for ADHD in ages 6 to 17. And you can see there's weight-based dosing for the short-acting for both clonidine and guanfacine. Guanfacine, I typically dose twice or 3 times a day. Clonidine, you can divide it up to 4 times a day. I don't have a lot of people that take it that often. Usually it still ends up being twice or 3 times a day if we're doing short-acting clonidine. And then the long-acting is supposed to be dosed once a day, both the guanfacine and clonidine, but in reality, I do sometimes split the dose and do a morning and an evening dose. And just some pearls about using clonidine and guanfacine. The long-acting and short-acting guanfacine are not equivalent. So 1 milligram of long-acting guanfacine is not the same as 0.5 milligrams twice a day of 10x or short-acting guanfacine. The 0.5 milligrams twice a day would be effectively more, right? So not all of the 1 milligram of guanfacine in the extended release is bioavailable. So it's not a one-to-one comparison. And if you make a one-to-one comparison, you're going to be giving more of the short-acting than you are of the long-acting. I also find that, I think anecdotally, some people will tell you that they see better response to the short-acting versus the long-acting, but that's really it's probably patient specific, but I will sometimes switch someone who's been on long-acting to short-acting to see if there's a difference. I will also sometimes switch from dosing in the evening to dosing in the morning to see if that makes a difference, and sometimes it does, even though technically it shouldn't make that much of a difference. I will also say in general, I use a lot more short-acting clonidine than I use Capve. I just haven't had a lot of good luck with Capve. I find that people they often have a paradoxical response to Capve where they are actually sleeping worse, but my short-acting clonidine works really well for insomnia. And I use that a ton for kids who have ADHD and who are having trouble sleeping. Okay. So I'm going to switch gears to norepinephrine reuptake inhibitors. So that would be your Strattera and newer medication, viloxazine, which is Qelbree. They both have the same mechanism. They both have a similar half-life. Side effects are similar for both of these medications. So it's fatigue, GI side effects, so nausea, vomiting. There is a class warning for suicidal ideation, like in our antidepressant medications. And then these medications can impact blood pressure and heart rate by increasing them. Starting with Strattera, which is available in generic and probably more commonly used. You can dose it twice daily. You don't have to, but sometimes that can improve tolerability. Unlike our alpha agonists, Strattera seems to be more helpful for inattention than for hyperactivity. And it can benefit anxiety. In some studies, it's been shown to have a benefit for anxiety. Certainly, I tell people at least it is not likely to make their anxiety worse, whereas sometimes giving a stimulant will worsen anxiety or will have someone complain more of anxiety. For Qelbree, they're extended release capsules, so you can open them and sprinkle them like you can for some of the extended release stimulant medications. There's some suggestion that it might start working a little bit faster than Strattera does, like on the order of 2 weeks versus several weeks for Strattera, 2 to maybe 4 for Strattera. This is not off-label yet. It's still under patent, so it's more expensive, and typically that patients will need to fail Strattera to have access to Qelbree. Again, there's weight-based dosing or age-based dosing, depending on which one you're using. I think a lot of people find that Strattera is really not effective for most people unless you're at the higher end of the dosing range, so that 1.2 to 1.4 milligrams per kilo daily. But for some people, it does work once you get up to that dose range. Monitoring, you're going to want to monitor vital signs, so blood pressure and heart rate on these medications. In my Carlat that I was just referencing, it says to check a baseline renal function for using Qelbree. I don't know that I have read that in other sources. I don't use a ton of Qelbree. For Strattera, it's LFTs, liver function test as needed, but you don't need to do any baseline labs. And the as needed is like if somebody has jaundice, basically. Okay. So if you look at head-to-head comparisons of, okay, so we have these medication options that are non-stimulant medications. Well, which one should we choose, or how, which one is better? Obviously, there's certain situations that clinical situations that you may choose one or the other. But if you look at studies that directly compare them, which are few and far between, but they do exist, they found that guanfacine outperformed, it was Strattera, the NRI for symptom improvement. It outperformed the NRI for appetite suppression. So Strattera does have associated appetite suppression. Guanfacine does not. And then they were equal on a broadband measure, which is more of like a global, is the patient better or not? Studies directly comparing non-stimulants versus stimulants tend to favor stimulants. We kind of already know that, right? Stimulants are typically our first choice unless we have a reason to not be able to use a stimulant for a particular patient. Indirect comparisons also tend to favor stimulants. If you look at some subsets of data, it looks like maybe Strattera is a little bit more helpful for disruptive behaviors, for what that's worth. Though, again, I would say like largely the pearl that I remember is that I like to use alpha agonists for impulsivity and ultimately for disruptive behavior. So I don't know that that is borne out in my clinical experience. I did want to talk about Wellbutrin or bupropion. It's not FDA approved for ADHD, but it is used off-label for ADHD, and I really like this medication. It unfortunately does not have FDA approval in kids, but I use it for older teens and young adults. Half-life is 21 hours. It has a kind of similar side effect profile to a stimulant: agitation, irritability, insomnia. You can have GI side effects. You can have appetite suppression. There is a small risk of seizure with this medication. However, it's much lower now that we have an extended release formulation, and that's pretty much all I use. It's contraindicated if the patient has a history of eating disorder. This is a really great medication. This is an antidepressant. So if you have somebody who has ADHD and depression, Wellbutrin is a good choice, and many people tolerate this medication well. It only has an FDA approval for major depressive disorder, seasonal affective disorder, and smoking cessation. These are all in adults. But again, I would say it gets used pretty commonly. I try to keep it like to ages 14 and up. And I talk to patients about it being off-label. I use 150 milligrams daily in the morning, the XL formulation, and I will increase it to 300 or 450. Again, typically in my adult-sized teens. And I monitor vitals and weight. This similar to the stimulants, similar to the Strattera or the Qelbree, you can have appetite suppression with this medication. Okay. I'm going to comment briefly on some other types of treatments that are out there. So neurofeedback. Neurofeedback has been around for a long time. It really hasn't performed super well in the studies. This most recent review that I was looking at showed that with a low quality of evidence, there was a significant effect on ADHD symptoms, no effect on disruptive behaviors, no effect on functional impairment. And I found this was a 2022 study in the American Journal of Psychiatry, someone saying, is it time to call it quits for ADHD? Reviewing some of the data and saying this really isn't very strong data. I don't think there's a risk to neurofeedback. I just try to discourage patients from taking a big financial hit to pay for it if it's not if it's accessible to them and they have a lot of resources, that's okay if they want to try it. But I try not to have people, put themselves out financially to access it. And then vitamins and supplements, interestingly, I had thought there was some okay evidence for omega-3s, but it looks like when they put all these studies together in aggregate, there really was no effect for the omega-3 fatty acids. I do sometimes still recommend them to people because I think they have other health benefits, but I don't recommend them above and beyond stimulants or non-stimulant prescription medications. And then if you take all these diets and supplements and put them together, this study found that in aggregate, there was a benefit for ADHD symptoms and disruptive behavior. Again, a low quality of evidence. And they couldn't separate out which intervention was actually the most helpful or had they said actually the zinc study had the biggest effect size, but ultimately I think again it's the level of evidence is low, and so I am not really recommending routinely these supplements for patients if they come across them themselves. I think again it's relatively low risk. A couple things I'll comment on in a minute. This was a 2021 randomized controlled trial. I heard about this in the psychiatry world. I don't know if it made it to the pediatrics world. This was for micronutrients. This is a pill that has a bunch of vitamins and amino acids. It is expensive, and you have to take 5 pills 3 times a day or something like that. The dosing is really onerous, and that has been a criticism of this. So this is this hearty essential nutrients. There have been 2 randomized controlled trials, and basically they were not super strong, in my opinion. They showed improvement in attention only by clinician ratings, not parent ratings, and improvement in emotional regulation. And then the second RCT showed clinical global impairment improvement, but no difference on the symptom inventory. So again, the studies are not super strong, and I think this is lifestyle wise, not a lot of families are in a position to be able to take this as prescribed or as recommended. There is a external TNS system that has been a FDA approved device for ADHD. There is a randomized controlled trial. It was felt to be safe, but again, the approval, the necessity criteria to get an FDA device approval is much lower than for a medication. And so there's not really a whole robust body of evidence for this. I'm interested. I hope they study this more. But this quote I have at the top basically is from one of these pediatrics papers, and it says, the TNS cannot be recommended as a treatment of ADHD without considerably more extensive study on its efficacy and safety. So I think this is probably a wait and see. But I'm, interesting option that is out there. The other one I get asked about a lot is the Endeavor RX video game, which is also FDA approved device, I guess, video game. And the thing that I would say about this, I do not recommend this. I try to steer families away from this for a number of reasons, but I think the studies that they did for this video game, they weren't doing ADHD symptom ratings. They were doing this TOVA, attention performance index, which is basically, they're training kids to be able to perform on this computer-based test of attention. And it doesn't really contextualize. I have not seen evidence that this really contextualized to ADHD in the real world. It just gets kids better at doing this computerized test, is my impression. And I think there are other risks associated with lots of screen and video game exposure that is already a parenting challenge for kids with ADHD and parents of kids with ADHD. Exercise, unfortunately, did not perform very well in the studies, and there was no significant differences. I still recommend exercise for all my patients because I think it's good for them for other reasons, but there's not a dramatic body of evidence that supports exercise as a treatment for ADHD. Okay, and I am going to quickly go through a couple cases to share some other resources with you as well. So JR is a 4-year-old, otherwise healthy male who's been newly diagnosed with ADHD combined type. Parents do not wish to try a stimulant, but are open to a medication trial. And JR is 18 kilos, so like 40 pounds. So in this case, if we don't want to use a stimulant, this is a preschool age child, there's a combined type. So there's a component of hyperactivity and impulsivity. I probably would go for an alpha agonist for this kid. I would first facilitate parent training if I possibly can get parents access to that. And then I would potentially do a guanfacine immediate release at either 0.25 or 0.5 milligrams at bedtime to start, and then increasing either by 0.25 or 0.5 milligram intervals. If it's not overly sedating, you can move it during the day and dose it 2 or 3 times a day. You can crush the IR formulation of guanfacine immediate release. That's why I like IR for the littlest kids, because you can put it in like a spoonful of pudding or applesauce, if they can't swallow pills yet. There also are compounding pharmacies that will make a liquid version for some people. I have heard of this happening. I haven't had a huge degree of success with it, but of guanfacine. And I did want to actually point out on this slide that there recently was an FDA approval for a clonidine liquid oral suspension. That's for the extended release clonidine. And it's the first and only liquid non-stimulant ADHD medication that should come to market in 2025, is my understanding. So something to look out for. It's been approved. I also wanted to talk about pill swallowing because that comes up in this age group. Whether particularly if they're not going to be taking a stimulant, you don't have very many options. In stimulants, you have the patch, you have the liquid, you have chewable. In non-stimulants, you have a lot more limited dose forms of medications. So I will give people resources to help their kids with pill swallowing. This is a pill swallowing cup you can get on Amazon in the picture. And there's also videos on YouTube that will walk kids through like basically instructions of how to learn how to swallow pills. And I have had families who have found both of these resources really helpful in teaching their kids how to swallow pills. There are also handouts. You can encourage people to swallow Tic Tacs or Nerds or mini M&Ms to practice. And occupational therapy or CBT therapists that have worked in hospital settings can sometimes help families who need really hands-on help with helping their kids learn how to swallow pills. Okay, so a second case, EM, is a 12-year-old female who's been prescribed Strattera at 1.2 to 1.4 milligrams per kilo for a year and is complaining of stomach upset along with a worsening of previously well-managed ADHD symptoms. And parents are wondering if there are any other options. And so for this situation, so this is a kid who's on a non-stimulant at an adequate dose, is having side effects, and is also complaining of, not as well managed ADHD symptoms. So there is not one right answer to this situation. Things that I might consider from a medication perspective would be to switch this kid to Quellbri if the Strattera had previously worked but was no longer working anymore and is having some side effects. I might consider decreasing the dose of the atomoxetine and then adding, if she hasn't tried a stimulant, adding a small dose of a stimulant or adding a alpha agonist, so to try to get away from the side effects, but then still have enough medication on board to manage the symptoms. And this is a kid who I also would try to dive in a little bit more about what aspects of ADHD are actually the most problematic and try to address with some non-medication options as well, right? So if, family comes in and they say that ADHD is worse, you can dial down a little bit more into what is actually the main problem. And so that's what I really wanted to present with this case, is this idea of a hierarchy. This slide comes from the ADHD Dude, which I referenced before, which is just a parent training resource that you can, you certainly can direct families to. I don't have any relationship with him, but I like this idea of a hierarchy. Basically, you might do different things depending on how ADHD is impacting a kid. So if there are disruptive behaviors or behavioral concerns, that would be a role for parent behavior training. If the child is really struggling in school with the schoolwork aspect of things, there might be a role for executive function coaching, which could either be for the parent or for the child. More commonly, I see it directed towards the child. In this diagram, they have it for the parent. If the issues are really with social interactions, then that is where you may be working with parents to help support their kids building social skills, or maybe the child is doing a social skills group, or maybe you're encouraging them to do individual therapy, like CBT therapy, focused maybe on social anxiety, let's say, or social skills. And then you can see at the very top of this triangle, I think this is the other point he's trying to make that I'm going to reiterate again. The smallest piece of the puzzle is the coaching that is directed towards kids. And that is because, again, the nature of ADHD makes it hard for kids to generalize what they have learned and to apply it. So they really need that in the moment coaching, which typically comes from their parents, their teachers, and to some degree, professionals that work with them, other professionals that work with them. But not as effective if it's once a week in a therapy setting. The other thing I wanted to just remind you, this is, I don't know if folks were on the stimulant presentation, but this is the ADHD medication guide. It is available online. You can print this out. It has stimulant medication, but it also has non-stimulant medication. So this is the picture of the stimulants, but they also cover the non-stimulant medication. So if you want a reminder of what is out there, does it come in a pill? Does it come in a liquid? What are the doses? I recommend this. It has everything you need in terms of those basics. And I'm going to stop there and take any questions. And then as a reminder, I will talk about SSRIs in September if anyone is interested in hearing about prescribing SSRIs from a pediatric perspective as well.
By the way, you can ask straight up questions, or you can bring up a de-identified case that you've had. If you've seen a kiddo recently and well, I guess you explained it so clearly.
Okay, I guess so. I guess we have no questions. Well, I am happy to, if anyone has any burning questions, I'm sure you can get in touch with, is there something in here?
Yeah.
A Q&A, okay.
Yeah, when you start a new medication, how soon do you follow up?
Yeah, so I tend to follow up when I'm starting most medications for ADHD. I will typically schedule a 1 month follow-up. I think 1 month is good for NRIs in particular. Strattera take a few more weeks to work. Stimulants, you typically don't need a whole month to figure out whether or not it's doing anything. However, my direct care is mostly in a private practice model where I don't necessarily have the ability to see patients super frequently because of other considerations. So I would say 2 to 4 weeks would probably be my standard for all of these medications. If it's a patient who has no other interventions and they are not meeting with any other professionals, I tend to see them a little bit more frequently. if they have a therapist, if they have other people they're meeting with, if they have case management or, even somebody at school counselor, I will often stretch out visits a little bit longer because I know that there's other people checking in with them. And one other comment on the how often do I see people, I will sometimes send people out with a stepwise titration plan. So for example, let's start 0.5 milligrams of guanfacine at bedtime. After 2 weeks, if it's going well, you can increase it to 1 milligram, or you can increase it to 0.5 milligrams twice daily. And that's the plan. If you have any issues with the plan, you can reach out to me and we'll change the plan, or we'll adjust the plan. But that way we can we don't have to keep, a low starting dose for the whole time, but you don't necessarily have to have such frequent appointments. Yeah. Okay. These are great questions. I got, so I see, the question is about Vanderbilt's. Do I get follow-up Vanderbilt's when titrating medication, or titrate based on parental observation? I do try to get follow-up Vanderbilt's. I agree, it is really challenging. I don't always, certainly if the parent gives a good history, I don't require a Vanderbilt to make a change in medication because I know it's really unrealistic sometimes to get them. But what I've been doing recently that has been really helping is I have a way to send the screening forms electronically directly to the teachers, and they can fill them out electronically, and there's no handing it to the parent and having them remember to give it to the teacher. And that has really increased my ability to get that information. I also, I don't know, this is just a convenience thing, but I tend to like to get them at the beginning of the school year, like in September or October. And I really try hard to do that to kind of see where we are. And then throughout the year, I do the best I can, but I don't always use them. Okay, I see a question. This is about a kid who is hiding her Adderall. And I think it's in terms of resources. I mean, I think maybe and they're not, art therapy isn't always the best fit for a kid with ADHD. I would say you certainly could give some of the Russell Barkley. He has books, many books, including books directed towards parents. So giving them resources by Russell Barkley. There's also videos on YouTube. You can Google Russell Barkley talks, like TED Talks and things like that. And you can, so parents can get some high quality information that way. In terms of the actual hiding of the medication, I would really encourage them to create a token economy around taking the medication. So creating a reward system for having taken the medication and supervising. So an 8-year-old, mom or dad should be in the room while the kid is taking the medication and should kind of watch them swallow it. And I think sometimes families run into trouble when they leave the med on the table for the child and the child's expected to kind of take it and swallow it on their own. I would just kind of try to increase the supervision there in terms of like a behavioral strategy and have a reward associated with taking it. Oh, great. Okay. Yeah. Yeah, you guys can certainly get in touch with Shai, who sent out the links to this talk today. If you have any more questions, I'm happy to try to answer them, and I will send some resources along via Shai, the contract that I was mentioning, as well as the stimulant resources for stimulant shortages that we are working on.
Absolutely. And this has been recorded, so we're going to send a recording to everyone. And all the recordings of all the sessions we've ever done are on forthealth.com/resources. So you'll find sessions with pediatricians, for parents. You'll find suicide prevention kits from the American Foundation for Suicide Prevention. There's a lot of good stuff. And yeah, pretty much at time. So thank you, Dr. Harmon, and thank you everyone for joining us. And we'll see you in September.
Thanks so much.
Bye-bye.